private center, but Dr. Abdawad is well known as a good presenter, and he has a well-established nephrotube, and it is available. And I think you will find the link for nephrotube. He will present it to you. Dr. Abdawad is famous by his nice presentations and algorithms. Today, he will discuss the issue of anticoagulation in dialysis. Dr. Abdawad.
Thank you, Professor Hussein. Actually, I will talk about hemodialysis anticoagulation. It is one of the most important topics that we meet in our practice. It is a very large topic to be covered in one lecture. Okay. Starting by the most or the well-known extrinsic and intrinsic clotting pathways that occur normally in our body for the formation of blood clot, starting by many of inactive proteases in our body that are activated in a sequence for the formation of blood clot. In hemodialysis patients, the precipitating factor that activates both intrinsic and extrinsic pathways is the contact of the patient's blood with the hemodialysis filter. This is why our patients on hemodialysis are at high risk for coagulation and for clotting during hemodialysis session. This is my talk outline regarding the different anticoagulation procedures that can be used during the hemodialysis session. There are heparin-related anticoagulant mechanisms, citrate-related and others. I will talk in depth regarding the heparin-related anticoagulants, and I will talk in short regarding the other anticoagulant methods. Starting by the heparin-related anticoagulants, the most famous and the most commonly used heparin-related anticoagulant is the unfractionated heparin. The site of action of unfractionated heparin is by blocking the activated factor 10 and blocking of activated factor 2, which is the thrombin. Actually, unfractionated heparin acting by forming a complex with the circulating antithrombin 3. The unfractionated antithrombin complex attached to the activated factor 10 and inactivate it. Also, the length of the unfractionated heparin is long enough or tall enough to combine also to the activated factor 2 thrombin and inactivate it. This is how unfractionated heparin inactivate both factor 10 and thrombin factor 2. Many heparin administration methods are available. Actually, there is no ideal method or highly recommended method for the use of heparin. All methods are different center experiences. Generally, they are divided into three major methods: method A, B, and C. All of them started by initial bolus of heparin at the start of the dialysis session. Method A and method B are using routine heparin initial bolus, which is a large initial bolus dose. Method C using a small dose initial bolus called tight heparin. Then they continue the dialysis session method A and method B by constant infusion heparin. Method B continue by one of two methods, by repeated bolus, many boluses after the initial bolus, or they only give the initial bolus without any further doses. Starting by method A, initial bolus followed by constant methods of infusion. Different protocols are available. As I said, there is no ideal protocol. Some centers using unfractionated heparin during intermittent hemodialysis using an initial bolus of 2,000 international unit, following by infusion dose of 1,200 international unit per hour. The European Renal Practice Guidelines recommending initial bolus dose of 50 international unit per kilogram, followed by 800 to 1,500 international unit per hour. If the heparin is used for CRRT, one of the most famous recommendations is to use 30 international units per kilogram as initial bolus, followed by about 5 to 10 international units per kilogram per hour for infusion dose all over the session of dialysis, targeting activated partial thromboplastin time to be 1.5 to double the normal times. Do we need to monitor the heparin clotting tests during the heparin usage? Do we have to repeat the activated partial thromboplastin time to monitor the level of heparin in the patient's body? Actually, in practice, therapy is ordinarily done without monitoring of coagulation. And if we are afraid because the patient is at a risk of bleeding, actually we use heparin-free dialysis. So in practice, actually there is no one using the clotting test to monitoring the heparin in our hemodialysis patients, although it may be written in some texts and some articles. Regarding the second method, which is using the routine heparin at the start, followed by repeated boluses or only the first initial bolus, different protocols are available. Some centers use 4,000 international units as initial bolus, followed by subsequent repeated bolus when needed if they felt that there is some clotting in the hemodialysis filter or machine or lines. This is my own center experience. We start with 2,000 international units as initial bolus, followed by 1,000 international units at the beginning of each hour or at the start of each hour of the hemodialysis. And some centers use 2,000 international units at the initial bolus without no repeated boluses. Regarding the tight heparin method, actually it is not popular and it is not used that enough. Its indication is mainly in patients who are at slight risk of bleeding. Actually, if there is a slight risk of bleeding or moderate to severe, we prefer mainly to avoid heparin as anticoagulant. So it is mainly used in patients with slight risk for bleeding. How it is used? They obtain a baseline clotting time, followed by initial bolus dose 750 international unit. Then they recheck clotting time after 3 minutes. If they didn't reach desired clotting time, they administer another supplemental bolus dose 750 international unit. If desired clotting time is reached, they start dialysis with heparin infusion at a rate of 600 international units. This is a minimum dose, tight dose of using heparin. Then they monitor the clotting time every 30 minutes. It is sophisticated and it is considered as a headache for the nursing staff and the doctors in the hemodialysis unit. So it's better to avoid heparin totally in patients with any level of risk of bleeding. Okay, if there is clotting in spite of use of anticoagulant, even heparin or others, if that means that I am not using the sufficient dose of heparin, yes, maybe yes, but don't always blame heparin, because there are many other causes that cause clotting of the hemodialysis system, even if you are using the correct dose of heparin. So don't always blame heparin. There are many other causes. For example, retained air in the dialyzer, inadequate priming of the line and the filters, kinking of the dialyzer and the line, vascular access, inadequate blood flow, recirculation, or repeated interruption of the blood flow due to repeated machine alarms and the nursing stop the machine several times. And surely, if there is a problem within the heparin administration. So heparin is one of the many causes of the clotting of the filter and the line of the machine. Okay. But if there is recurrent clotting and I excluded all other causes, so we have to readjust and re-evaluate our heparin dose. What are the main complications of heparinization? First of all is bleeding. Incidence of bleeding is about 10 to 50%. Mortality due to bleeding is as high as 15%. The risk of bleeding is proportional to the activated partial plastin time and not to the heparin dose, so it may be individualized in our patients. Not all patients may receive the same dose of heparin. One of the most important causes of bleeding, if or one of the most common manifestations of bleeding is post-therapy needle puncture site. After you remove the needle from your patient after the hemodialysis, you have a continuous bleeding which is prolonged. Many of us assume because the patient has overdose of heparin during the dialysis session, but again, don't always blame heparin, because there are many other causes and important and common to cause the same presentation. Yes, you have to evaluate your heparin dose, but don't forget that outflow stenosis of the vascular access is one of the most common post-therapy needle puncture site bleeding due to high pressure, which delay the occlusion of the needle. And again, evaluate your nursing needle insertion technique. The second complication of heparin is heparin-induced thrombocytopenia. This is a large topic. I will cover it in very short words. Heparin-induced thrombocytopenia is heparin exposure plus thrombocytopenia plus minus thrombosis. The main cause is due to IgG antibodies that are formed against the platelet factor 4 heparin complex. The main management is to stop heparin, even unfractionated or low molecular weight heparin that I will talk about, and start non-heparin anticoagulants. This is in short. I recommend for you one of my lectures, which is heparin-induced thrombocytopenia on NephroTube website. I will put the link at the end of the lecture, that I talk in depth and in details in the causes and the management and dosing of anticoagulants in heparin-induced thrombocytopenia. Other heparin-associated complications: hyperlipidemia and lipid disturbance, hyperkalemia, reported cases with pruritus, reported cases with anaphylactoid reaction, especially with first use, reported cases of osteoporosis, and reported cases of alopecia. This is regarding unfractionated heparin. Regarding low molecular weight heparin, low molecular weight heparin has a lower or smaller molecular weight than unfractionated heparin. Actually, low molecular weight heparin is formed from unfractionated heparin by enzymatic degradation. The main site of action of low molecular weight heparin is mainly by inhibiting activated factor 10 and the slight weak effect against thrombin. This is because the length of low molecular weight heparin is short. So when it forms a complex with antithrombin, this complex is long enough to inactivate factor 10, but it is not long enough to inactivate thrombin activated factor 2. So this is why it has a good anti-factor 10 activity, but a weak antithrombotic activity. Regarding the comparison between low molecular weight heparin and unfractionated heparin, low molecular weight heparin has a longer half-life, more rapid onset of action, higher bioavailability, more predictable effects, less non-specific binding to endothelium and platelets, less platelets and leukocyte activation, and it has no antidote. It is not reversible with protamine sulfate as unfractionated heparin. Regarding side effects, it has less risk of heparin-induced osteoporosis. It has less bleeding and less thrombocytopenia, but heat heparin-induced thrombocytopenia can occur with low molecular weight heparin. Less hyperkalemia, less disturbance of lipid profile, and anaphylactoid first dose as unfractionated heparin. Regarding the most important two complications for the comparison between low molecular weight and unfractionated heparin are bleeding and thrombosis. This is one of the most important meta-analysis comparing low molecular weight heparin and unfractionated heparin regarding bleeding as a major side effect. There was no difference between low molecular weight heparin and the unfractionated heparin regarding bleeding from vascular access. Also, they compared both drugs regarding thrombosis. There was no difference between low molecular weight heparin and unfractionated heparin regarding the incidence of thrombosis of the extracorporeal circuit. This is why the European Renal Practice Guidelines recommend low molecular weight heparins as the first preferred line for to be used as an anticoagulant during hemodialysis than unfractionated heparin. But actually, low molecular weight heparin are very expensive, and as they are not superior to unfractionated heparin is widely used. Here and in Mansoura and in my city, Alexandria, the most commonly used is unfractionated heparin because it is of low cost in relation to low molecular weight heparins. If I will use low molecular weight heparin for intermittent hemodialysis, there is different dosing for different drugs, but the main idea that they have longer half-life, so single dose at the start of dialysis is efficient and sufficient. If there is extended dialysis session, splitting the dose is important. Regarding CRRT, can I use low molecular weight heparin? It is not widely used in CRRT. And even it has no reduced bleeding or increased filter survival and very low experience for the use of low molecular weight heparin in CRRT all over the world. How to be monitored? It is not monitored by activated partial thromboplastin time. It is activated by anti-factor 10E, which also is not available and difficult to be obtained. So this is one of the drawbacks to the use of low molecular weight heparin. One of the most important heparin-related anticoagulant methods is heparin-free dialysis, not use heparin. When not to use heparin, if the patient is high risk of bleeding, for example, if it's pericarditis, recent surgery, coagulopathy disease, thrombocytopenia, intracerebral hemorrhage, active bleeding, and even there are some centers that use heparin-free dialysis as the main protocol for anticoagulation for hemodialysis patients. I think here in Urology and Nephrology Center in Mansoura, they are using the heparin-free dialysis even if the patient is not at risk of bleeding. How to use this method? Start by heparin rinse. Rinse extracorporeal circuit with saline containing 2,000 to 500 units of heparin. Then drain the heparin containing priming fluid from your machine out of the dialysis machine by unheparinized saline. Then set the blood flow rate at 250 to 500 ml per minute, and the periodic washing of the hemodialysis filter and the machine during the dialysis session by about 50 to 250 ml saline every 15 to 30 minutes. The first step is optional, especially if the patient has heparin-induced thrombocytopenia, so I may avoid. And the periodic rinse is important to follow up the hollow fibers if there is a clotting fibers appear, so the rinse must be of a larger volume and more frequent. If I use the heparin-free dialysis for CRRT, it is better to use the pre-dilution method to prevent hemoconcentration in the dialyzer. And it is important to keep the blood flow at about 200 ml per minute or higher to prevent the stasis of the blood and the dialyzer anticoagulation. Regional anticoagulation with glutamine reversal actually is a historical method now, but I will mention its main idea. Its main idea that when the blood came out of the patient, they introduce a very high dose of heparin to anticoagulate the blood. Then, when the blood is coming back to the patient, they administer the antidote of heparin, which is glutamine, so to combine with heparin and neutralize the heparin. But actually, this is technically very difficult and rebound bleeding 2 to 4 hours after the end of the dialysis had been occurred. This is because the heparin-glutamine complex that enters the patient body is slipped away heparin-glutamine by the reticular endothelial system, which will elevate the heparin level in the patient body and lead to catastrophic bleeding. One of the methods of heparin-related anticoagulation is heparin-coated filter. Actually, this is under studies and experiments. Many studies used heparin-coated filter without systemic anticoagulation, and the results are not good. The coated